Welcome, everybody. As you're getting logged in here, we'll just give a minute or two to let people file in before we kick it off. And maybe just the 30 seconds or so, and then we'll get going here. All right, great. So we're a few minutes past the top of the hour. Thank you, everybody, for joining us. Good morning. My name is Mike Gardner. I'm an orthopedic surgeon at Stanford University, and I'm thrilled to be joined this morning by one of my colleagues, Dr. John Voorhees, one of my partners here at Stanford. And we'll turn it over quickly to John. We've started the National Scoliosis Clinic, and John's been a part of this to really help patients in their journey in their scoliosis care. There have been a number of challenges with the current standard historical system for how scoliosis patients get care, how they get information, and how they get their scoliosis followed. So we'll get into it, just kind of some of the basics of scoliosis in a minute. But first, I'll turn it over to John. John, maybe you could just give us a brief overview of your background and how you became to this point in your career as an expert in scoliosis, and then we'll go from there.
Thanks, Mike. So yes, I'm John Voorhees, and I am an orthopedic surgeon at Stanford, and I'm a pediatric orthopedic surgeon specifically with an interest in scoliosis and spinal deformity. So the way I got to that position was I did a residency in orthopedic surgery, and then I went and did another year of specialized training in pediatric orthopedics. The vast majority of that was dedicated to scoliosis, and I did that training at Scottish Rite Hospital in Dallas, Texas. And then I came back to Stanford, and I have been practicing for my entire career afterwards at Stanford, where I take care of almost entirely patients with scoliosis and then a few other patients with general pediatric orthopedic concerns.
Great. Well, thanks a lot. So we know there's a lot of information out there in the internet and other places. We thought it would be great to start with a succinct, kind of comprehensive overview of the kind of the basics of scoliosis from a national expert. And so, John, maybe you could just start with an overview of some of the basics of scoliosis.
Yes, thanks. I'd love to do that. So I have a few slides. Part of my job here at Stanford is to educate doctors in training. So I teach medical students and I teach residents. So I have some slides prepared that are based on the same information that I present to physicians who are learning how to take care of patients with scoliosis. So I thought it would be wise to start with a general overview of scoliosis. I know we have a lot of different people who might sign up for this webinar with different backgrounds. Some people might know a lot about scoliosis already, but some might be just getting introduced to it. So just to get us all on the same page, I'll give this brief overview. So scoliosis, as it is defined in the textbooks, by doctors is defined in 2 dimensions. We know that scoliosis is a 3-dimensional curvature of the spine, but we have this imperfect number that we use to define it, which is called the Cobb angle, or measurement by the Cobb method. There are many different measurement techniques to measure scoliosis and to define how it affects the body, but all of our treatment is designed on this one, albeit imperfect measurement. So here's how we do it. So we take, it's defined on an AP or a PA X-ray measurement. So your child stands, and then there's an X-ray taken from the front or from the back. And we look at the spine. We look at the most tilted vertebra at the bottom of a given curve, and the most tilted vertebra in the other direction at the top. The computer extends that line out into space and measures the angle between them, and that's called the Cobb angle. And scoliosis itself is defined as a Cobb angle of over 10 degrees. And many patients have a Cobb angle of over 10 degrees. It's actually fairly common. We actually don't know how many, because there are many people running around with a Cobb angle of just mildly over 10 degrees that might not even know about it. So most curves progress during growth. And after a child is done growing, most curves do not progress. That's sort of a basic understanding of the natural history of scoliosis. Small curves are very common, and they usually don't really cause that many problems to patients' health-related quality of life. They don't cause back pain. They don't cause problems with breathing or internal organs, so we don't necessarily have to worry about them. Moderate curves, though, might have this risk of progression during growth into large curves. And large curves tend to progress even after somebody's done growing, and they tend to cause problems. Those problems can relate to back pain, worsening function of the lungs. They can cause problems with bad posture or sitting balance as well. So those are the ones who are indicated for treatment. So here's an example of a patient who has a relatively small curve on the top, so that measured 13 degrees, and then a 22 degrees, so approaching a moderate curve down below. And then here's an example on the right of an adult. And so you can see the spine looks a little bit different, and the curve has progressed. And this is an example of an older patient who might have a stiffer curve that is more likely to cause problems with quality of life. So as I mentioned, scoliosis is an abnormal rotation and curvature of the spine, and a hallmark of it is that it worsens with growth. So this is a typical example of someone who might present to my office with a fairly severe scoliosis. And you can see the X-ray there is a curve in the chest to the right and a lumbar curve to the left. And this is a typical example of what you might see when you examine such a patient or when you look at your own child's back. So some of the things that I'm seeing as I look at this picture are a little bit of an asymmetry in the shoulders. The left shoulder is a little higher than the right shoulder. Sometimes it can be the opposite, with the right shoulder higher than the left. There's what we call a trunk shift. So the rib cage is actually shifted to the right relative to the pelvis. And then you can see some asymmetry in the waistline and the shoulder blades too. And when she bends over, you can really see the rotational component of this spinal deformity. And as she bends over, the ribs are sort of pushed back on her right side. So all those things that we see when we look at a patient with scoliosis are things that doctors are looking at, and pediatricians and school nurses are often looking at to screen for scoliosis. So I wanted to give you an example of what how a typical adolescent idiopathic scoliosis patient makes it into my clinic. So most of the time, in this country at least, children are screened annually by their pediatrician, and that might be a pediatrician or nurse practitioner or physician assistant, a primary care provider of some sort. And then in some states, in some areas, people are also screened by school nurses. So when a patient screens positive, or a kid screens positive, that means somebody thought that there was something a little bit asymmetrical about their back, might indicate they have scoliosis. And then maybe if they get screened by a school nurse, they get sent to a pediatrician, and the pediatrician, depending on their experience level and their training, might just look at a child's back and use their experience to judge whether or not they think they have scoliosis. Or they might use one of these devices here that I pictured called a scoliometer, which is based on a carpenter's level, and tries to quantify the shape of the back and decide the risk that a patient might have a real scoliosis. And then they get sent to somebody like me, who's an orthopedic surgeon, and I'll examine them. Maybe I'll get an X-ray, and then I'll decide based on what I see in the X-ray whether they need to be monitored, whether they need to be treated, or whether they need some kind of non-operative or operative treatment modality. And often that involves a fair bit of X-rays over the course of a patient's life. And the reason why we get so many X-rays is because our we need to understand whether or not a patient is indicated for treatment. And our treatment algorithms and guidelines are based almost entirely on this Cobb angle measurement. And so here is a rundown of how we decide what kind of treatment patients are indicated for based on how much growth the child has remaining and how big their curve is as measured by the Cobb angle. So these are generally agreed upon guidelines by most surgeons, though there's some gray area on where the definitions and the lines fall between these treatment groups. So in general, if you have scoliosis, but your curve is under 20 degrees, most people will say that you are indicated for monitoring. So there's not a whole lot of evidence that brace treatment will change the outcome in somebody like that. So usually we'll just watch those patients. And the reason is because a lot of these patients won't get worse. If you have a really small scoliosis, we don't want to overtreat and provide treatments that won't necessarily enhance the quality of life of your child or change their risk of having problems in the future. Then if you fall into this moderate category, which is generally thought of as between 20 to 45 degrees, those are the patients who are really indicated for brace treatment. And to be clear, if you fall into a moderate curve category and you have a lot of growth remaining, that's when you really stand to benefit from bracing, because bracing can modulate growth. So patients with documented progression or skeletal immaturity, meaning they have a good amount of growth remaining, and they're in that moderate category, could benefit from bracing. And then if your curve gets over 45 or 50 degrees, that's who we generally understand through natural history studies will continue to worsen throughout life. And those are the patients who might benefit from surgery. And then over on the right there, I put physical therapy. Physical therapy is a new treatment mode. It's a more commonly accepted treatment modality nowadays, even though it's not new. It's been present for many, many years. And it can be applied really at any point. It can be applied to patients who have some postural asymmetry, but maybe they have a curve that's too small to really benefit from bracing. And it can also be applied during the bracing period. And it can also be applied to patients who might be indicated for surgery to help strengthen their core and help their overall posture and body awareness. So a word about some of these treatment modalities specifically. So the brace is by far the most effective non-operative treatment modality that we have. It's a customized orthotic, so it's built to fit a given kid. It's not a quick fit or a one-size-fits-all sort of an apparatus. And it basically works by pushing on the curve through pushing on the ribs and sometimes the waist and the hips, depending on the curve type. And it straightens out the scoliosis when the kid is wearing the brace. When you take the brace off, the curve sort of slumps back down. But the idea is that if you wear the brace most of the time as you're growing, the scoliosis doesn't have a chance to get any bigger while you're in the brace, and instead the kid gets taller. And it's worn under the clothes. And really, for it to work, it has to be worn most of the day. So in some cases, we prescribe nighttime bracing only, but most of the time, if somebody's at risk of progression to surgery, we're prescribing it for 18 to 23 hours a day. And it has to be worn really through this period of rapid growth until your growth really tapers off and we call you nearing skeletal maturity. And these are examples of some of the braces that are prescribed. The first one there with the butterflies on it is the Boston brace. That's by far the most common brace. And then there's another example there called a Wood-Rigo-Chenot, which is a brace that focuses more on derotation. And then the red brace there in the end is an example of a Providence brace, or a nighttime bending brace. So most of our understanding about how to treat patients with the brace, what type of success we might expect and who would benefit from it, comes from this really important study that was run out of Iowa by Sue Weinstein and Lori Dolan, among others. And they did a prospective randomized controlled trial. So they enrolled patients who might have some benefit from bracing, and they randomized them to whether or not they would get a brace or be observed. And then they followed to see how they did. And they also did something very special. They tracked how often patients wore the brace by using a temperature monitor. And so they can actually tell how long people were wearing the brace and whether or not they were following directions. And it turned out that the patients who were randomized to wear the brace did dramatically better than the ones who didn't. And it was such a surprisingly profound result that the National Institutes of Health, who was monitoring the trial for safety, actually decided to end the trial earlier because they felt it was unethical to continue, because the benefits of bracing were so profound that it wasn't fair to not offer them to all patients in the group. So they found also that not only wearing the brace, but wearing the brace for more time increased your chances of success. So there you can see a graph of that. So as hours per day in the brace goes up, then the chances of success of treatment also go up. Okay, so then we'll talk a little bit more about some of the other non-operative treatment modalities. So Schroth physical therapy. So there are many different types of scoliosis-specific physical therapy, and all of them have different potential to be effective. By far the best studied, and the one I'll focus on, is called Schroth physical therapy. So it was developed in Germany by Katharina Schroth, and then later modified in Spain. And then there's many different subtypes of it that are around. It's a physical therapy modality that focuses on teaching body awareness, asymmetric muscle strengthening, improving breathing techniques to really teach a patient to be aware of their body and how the scoliosis might be affecting their posture, and then teaching them techniques to consciously correct their posture and thus correct the shape of their spine and their body as it relates to the scoliosis. And a lot of the other therapy modalities that are not Schroth use some of these same modalities but they come to it from slightly different angles. It can be used independent of or with a brace. So patients that are pre-bracing, during bracing, or maybe never really indicated for bracing can benefit from this. It can strengthen muscles and help you improve posture related to scoliosis. So then I'll talk briefly about surgery. So this is not really the focus of this webinar. We're trying to help you avoid surgery, but I am a surgeon. So I do treat patients non-operatively and operatively. And as I say to families, I really like doing surgery. It's one of my favorite operations to do. But if it was my kid with scoliosis, I would definitely want them to get better without surgery if that were possible. But I think it's important for people to understand what the surgical options are if they might be indicated for your kids, or just what might happen down the road. So by far the most common surgical treatment for scoliosis is something called spinal fusion, most commonly a posterior spinal fusion. And so the number 1, 2, and 3 goals of this are safety. We want to get your kid through safely. We want to prevent progression later on in life, and we want to obtain some correction. And the way we do this is by fusing the spine. So we take a curved or crooked spine, we straighten it out using techniques where we release some of the bones, and then we hold it in place with metal screws and rods and fuse it together as one unit. So instead of having multiple different motion segments along the spine, we fuse it together so it moves like one bone. And this has been going on for many, many years. So it's a very refined technique, and every year, every decade, it gets safer and safer and safer. So now what it means for a patient is they usually spend 2 or 3 days in the hospital. They take 2 to 4 weeks off of school. They're back to most activities at 6 weeks, high impact sports, somewhere between 3 or 6 months. And it has a very low complication rate. Nobody wants to sign their child up for anything that has any risk of complications, but any surgery has some small risk of complications. So we think for scoliosis, major complications, which most of them don't cause any kind of permanent disability, but they do exist. So things like infection can be around 2 to 3%. And most patients don't need a repeat surgery after spinal fusion, but a small proportion do. That's the gold standard, but there is a new wave of operations that has really come to prominence in the past 5 or 6 years. So I wanted to talk about that. There's 2 devices now that are approved by the FDA to treat scoliosis surgically without attempting to get a fusion, and that's anterior vertebral body tethering and posterior dynamic distraction, both of which were approved in 2019 by the FDA through this humanitarian device exemption pathway. Anterior vertebral body tethering involves putting screws in sideways through the chest, and instead of a rigid metal rod to obtain a fusion, we place a flexible rope to guide growth, and we place that rope on the convexity of the spine. So in a child who has growth remaining, the curve might correct as the child continues to grow. The posterior dynamic distraction device goes in from the back, similar to a standard scoliosis surgery, but we don't expose the entirety of the spine, and we don't attempt to obtain a fusion. We just expose the top and the bottom, and then try to brace that patient internally. Both of these devices might have the potential to avoid some of the stiffness associated with spinal fusion, but still obtain some correction. The important thing to remember about these devices, though, is that they have very narrow indications. So the vast majority of patients with scoliosis won't actually be indicated for this device. So it might be a good option for a small subset of patients, but we're still learning a lot about them. And so every year that goes by, as more patients get them, we learn more and more about who really might benefit from them and what the risks and the benefits are compared to spinal fusion. So in summary, scoliosis is a 3D spinal deformity. It commonly presents in adolescents. And I really focused on adolescent idiopathic scoliosis for this talk, but there are other kinds. It's progressive during growth, so that's really the most important window for treatment. And untreated, it can lead to impaired quality of life when you're older. And early detection can really improve the success of non-operative treatment. So if we can detect what kind of scoliosis you have, and at the right time, we can offer some really effective non-operative treatment modalities to improve your quality of life and help you avoid surgery. Thanks.
Just outstanding, John. Thank you so much. Really helpful and clear and succinct. So we got some great questions out there. Please keep them coming. Yeah, you can go to keep presentation mode on there. So maybe we'll just get to the next part of this here, and we'll get to some questions at the end. So switching gears a little bit, we've got two different components to the National Scoliosis Clinic, and we'll discuss these briefly at the end. One of which is a really exciting technology we've been working on, not ready for prime time quite yet, but coming soon. And one of the issues with scoliosis is obtaining a number of x-rays throughout the monitoring period, which is typically during adolescence. And it adds up to a lot of x-rays, which is a lot of radiation to a growing child. So we're working on a method to assess the magnitude of scoliosis, to track it frequently without an x-ray on a smartphone. And so John and our team has done some really great research here at Stanford. And so he's just going to present some of that research here next. Thanks, John.
Thanks. So as I mentioned before, the critical thing is finding the right patient in the right window to benefit from treatment. And we have some pretty limited standard methods for how to decide if your child has scoliosis. And so really the crux of this research is trying to define who has scoliosis and screen for patients who might benefit from treatment without using so many x-rays. So just before I get into the new developments, I'll give you a little summary of the current state. So scoliosis screening and monitoring is usually done by experienced observers, and the main device that they have at their disposal to really help quantify whether or not they think you have scoliosis or what your risk for it is this thing called a scoliometer. So it's a very simple mechanical device based on a carpenter's level. There's a little ball bearing that slides on a little smile-shaped runway, and we place it on your child's back when they bend over, and we sort of define how big of a hump the rib makes when they do this. And so it is not perfect, though. It has a pretty high false negative rate of 30% and 20% false positive rate, which means that patients who don't have scoliosis get referred and get unnecessary radiation. And then sometimes patients who do have scoliosis are missed until the curve is too big or the child is too old to really benefit from these non-operative treatments. And the problem is that this device should not really be used alone for scoliosis screening. You need somebody who's experienced to look at all the other things about a child that might indicate that they might benefit from referral. But specialists who have a lot of experience in scoliosis are somewhat rare. There's 30 million children estimated who have no access to a scoliosis specialist for screening purposes. And so what this results is many scoliosis x-rays or chest x-rays, which can cause a real risk of cancer in patients who have multiple exposures to radiations in the period of rapid growth. So the system as it works has some holes, definitely opportunities for patients to fall through the cracks, and it can be often a stressful and frustrating experience for families. So this is an example of a typical child with scoliosis, and I showed you one of these before, but I wanted to tell you how it relates specifically to what we see when we look at a patient's back. So this kid, similar to the kid I showed you before, has a little bit of a trunk shift. So you can see the rib cage is shifted to the right and the pelvis is shifted to the left. There's a little bit of an asymmetry in the shoulder blades, also in the trapezius and the height of the shoulder itself. And then when she bends over, you can really see the rotational component. And you can see that the rib cage on the right is turned back a little bit. And that's because the spine is rotated and the ribs have their root on the spine. And so the rib cage is pushed posteriorly or back as the child bends over. And here's a schematic of how that happens there. You can see this, the vertebrae are rotated to the right, it's pushing the rib cage to the right. And that's really what the scoliometer measures when you put it on there. But as you can see, that rotational component in one spot of the spine is really all the scoliometer can measure, but there's so many other components when an experienced observer looks at the back. And so there are other methods to detect if a child might have scoliosis without x-rays. And one of the most promising is 3D scanning. So looking at the three-dimensional contours of the back and trying to determine who has scoliosis is not a new concept. It's an old concept. It's been around for many, many years. In fact, my senior partner, Larry Rinsky, who's retiring this year, wrote a research paper about this in the 1970s. And at that time, they were using a slit lamp topographical method to really quantify the contours on the back and predict who has scoliosis. And it works. It's very effective. But the problem is that for many years, the only way to get a really high quality 3D scan was to have essentially a whole room dedicated to this with some very expensive equipment. And then the data processing required to really digest these images and see who has risk or not was a very cumbersome process. And so the image acquisition has advanced over the years. The machines got more expensive and they're still fairly large, and it really didn't get adopted even though the methods existed. But now, in the past 5 years, we've had some really significant advances in imaging ability through smartphones. And so we now have the ability to obtain a fairly high quality 3D image through a mobile device. So the focus of this research I'm about to talk to you about is how us trying to understand if that kind of a 3D image could be used to scan patients with scoliosis and determine if they are at risk for being in one of these treatment windows. So our goal was to develop an artificial intelligence assisted clinical decision tool to facilitate detection of scoliosis based on mobile device 3D scans. So we wanted to improve the diagnostic accuracy of scoliosis screening from the existing screening method, which is scoliometer. We want to facilitate access to care for patients who might not be able to get to an experienced screener. And for patients who have scoliosis, we wanted to see if maybe we could use this to follow their scoliosis and reduce their radiation exposure over time. So this is a schematic of the general idea that you would do a data capture with a mobile device based 3D scanning technology. It takes about 90 seconds. This image would then get uploaded to the cloud where there would be some cloud-based AI processing. We can take several measurements on this 3D scan, and then we can get a number or some sort of quantification of your risk of having scoliosis, and that can guide the decision that a pediatrician might make about whether to refer a patient, or it could be perhaps done by a family at home, and it could give some indicator of whether or not scoliosis is progressive or not. So I'll just pause here and say this is our general idea, but we're still, this is still very much in the phase of research and development. So we're talking with the FDA and working on potential approval, but right now the things I'm telling you about are still in research mode, so not yet approved for general clinical use. But I have had the opportunity to do this research for several years now, and I'll show you some of the data that we've presented most recently at the Pediatric Orthopedic Society of North America meeting. And then we're going to be presenting some of this research also at the Scoliosis Research Society meeting this year in Seattle. So we've been doing this scanning method for several years as a part of research here at Stanford, and we've amassed scans on a large number of patients. And here's an example of some of the scans that we're able to obtain. So we've been taking patients that come in to see me and my partners at Stanford, so people who were referred by their pediatricians because they thought they might have scoliosis. Some of them did, some of them didn't. We looked at patients who were at risk for having idiopathic scoliosis, and we took scans in the upright and the bending position, as you can see there, and then made some 3D measurements on these. And so the patients that we have, I'll show you the results of about 260 patients. Most of these were adolescents, and we had a wide range of body mass index, so body types and curve magnitudes. Most of these patients have thoracic curves because that's the most common. And so just briefly to show you some of the results. So the first thing we did was we tried to correlate some standard X-ray measurements of shoulder position and trunk shift, like we've been talking about, and compare the measurements on 3D scans to X-rays. And we found that they were actually highly correlated. So here you can see graphs of, on the left, trunk shift, coronal balance, and clavicle angle. So trunk shift is that measurement of the center of the rib cage versus the pelvis. Coronal balance is whether your head's centered over your hips. And clavicle angle is a measure of shoulder asymmetry. And we found that what we measured on the 3D scan was actually highly correlated to what we measured on the X-ray. And then we wanted to see how it related to Cobb angle. So scoliometer itself, you get a degree measurement from the scoliometer, and there's a degree measurement from the Cobb angle, but they're not equal. They're loosely related. And so the graph on the left shows that relationship. And you can see it's fairly scattered. It's not a perfect relationship. And then we measured a similar angle based on the 3D scans, and we called it 3D trunk rotation. We found that that one was a little tighter correlated. It's not perfect, but it's much better. And that might be because we have a better ability to really evaluate the whole back and pick very carefully where we're going to make that measurement of angle of trunk rotation. So we presented some data at the Pediatric Orthopedic Society of North America meeting using all of these measurements, and found that combining all of these 3D measurements, we're able to much better predict who might have a Cobb angle of over 20, who might be indicated for scoliosis treatment, than just using the scoliometer alone. And then the next step for what we're evaluating is even more advanced methods of really evaluating that bending x-ray, not just looking at one angle, but instead using a 3D map of topography, surface topography. And many different authors have looked at ways to do this, and we're modifying those and using our own. And we've developed something called the Modified Asymmetry Index, which really tries to quantify some of that surface asymmetry. And we found in initial results that it's actually quite predictive, more predictive than the scoliometer is alone at deciding whether or not a patient might have scoliosis. So we're very excited about the potential that this might have to help people like me, and also parents and anyone really who is interacting with someone who might have scoliosis, because it might provide a diagnostic method that offers less risk, more convenient to families, and more accurate than existing methods. And we hope that it'll be less error prone than existing measurements, make the whole process more efficient for patients.
Did awesome, John. Thank you so much. Really, really outstanding stuff. So maybe just final piece here. We'll put it all together, and maybe you can just give us an example. Obviously, like, again, the entire patient journey from screening and detection to being referred to an orthopedic surgeon, et cetera, is complex. And so can you give us an example of a recent patient you've had that you remember where the system just worked perfectly? Like, how's it supposed to work perfectly? Everything falls into place, timing, access, et cetera. What does that look like?
Yeah, so we get lucky sometimes, and things work out really well. So really, I'll give you an example of a kid I saw recently. I'll call her Emma to protect her identity. We're not going to use real patient names on this, but so Emma came to me. She saw a pediatrician regularly, and luckily her pediatrician had a lot of experience screening for scoliosis, and saw a back asymmetry. Emma was just before her adolescent growth spurt, so she's about 10 years old, and we got an x-ray, and she had a curve of right around 22 degrees. And she was really ahead of her adolescent growth spurt. So for me, nobody wants to have scoliosis, but if you're going to have scoliosis, that's a great time to present, because you can really go either way. An untreated curve is at some risk of developing into a curve that might affect her quality of life, and it might put her at risk for surgery. But a 20-degree curve, 22-degree curve usually doesn't affect somebody's quality of life. She didn't have any back pain. So it's a great window for us to begin treatment. And so we were able to begin treatment with a 3D brace. So we use a WCR brace. And then we also began physical therapy to help teach her some body awareness, postural modification, and core strengthening techniques. And so because we caught her early, we could actually start a nighttime brace, which is something that I do and some of my partners do for patients who are before the adolescent growth spurt. And we were able to control her curve in a nighttime brace combined with physical therapy. And over time, as her growth became more rapid, we did ramp up her bracing for a period of time to full-time brace, and then back down to nighttime brace. And then at the end of treatment, somebody like Emma has a chance to end up with perhaps even a smaller curve than they started with, or in most scenarios, just the same size curve, but something that really doesn't bother them, they don't have to worry about it for the rest of their life. They don't need surgery.
Fantastic. Yeah, just great stories when everything works perfectly and kids get helped, and the system and the interventions work to avoid surgery. How about on the flip side now? Do you remember an example where some piece of the system failed and it just didn't work out well for a child?
Unfortunately, I do. Anybody who takes care of scoliosis is going to have examples like this. So I see kids pretty much every clinic that I see new patients. I'll get an example of somebody who I wish that I could have had the opportunity to see last year or 2 years ago. So the most recent example I can give you, we'll call her Madison. So she came in to see me, and she was maybe 2 years after her first ever menstrual period, so 2 years after her adolescent growth spurt, and she presented with a curve that was right at about 55 degrees. And so she, at 55 degrees, she already falls into this category of severe scoliosis. And so when she's mostly done growing, we don't have a lot to offer her in terms of brace treatment. So there are certainly treatments that we can offer her to improve her strength and overall balance, but that curve has basically already fallen into the category that we believe is likely to worsen over life. And so with that family, it's a really challenging visit for me and, the family, because we have to really talk about surgical options the first time I meet somebody, which is not ideal. And as a parent, I wouldn't want to see that. So those are examples of kids where I really wish I had an opportunity to intervene a little earlier to prevent, what I saw.
Right. Yeah. Thanks so much for that. So, we'll start wrapping up a little bit and get to the questions. So, what is the National Scoliosis Clinic? So we know that receiving a diagnosis initially of scoliosis is scary. And we know that ongoing assessment of that scoliosis can be difficult and can require a lot of radiation. Fortunately, there are a lot of proactive interventions that have been shown to work to prevent progression of the scoliosis, other than watching and waiting. And we know that watching and waiting and hoping can make patients and families feel powerless. So what we're doing at the National Scoliosis Clinic is assembling a bunch of virtual resources for parents and their kids around all of these. So there's an option for seeing a specialist, a scoliosis specialist virtually as a doctor visit. But additionally, there are options for things like talking to a bracing specialist live. So a lot of families have questions about the brace. What side can I sleep on? How often I do all these, and there are a number of these in the chat. So you can talk to a bracing specialist. You'll be able to talk to a physical therapist. And there's going to be some on-demand content for scoliosis-specific physical therapy that has been proven to decrease curve progression. So a number of things. There's an opportunity to talk to other scoliosis patients who are through their journey and have very valuable experiences to share. So we think this is a very exciting and helpful opportunity for parents to improve information gathering and also to be able to proactively treat their scoliosis. So we're launching all of this next week. If you go to nationalscoliosisclinic.com, we're offering a discount right now to sign up for a membership for some of these services. So please head over and check it out. So some great questions. Again, these kind of patient stories that are in the Q&A are very common. They are the reason we started doing this, is because patients can't get access to a specialist. They don't get the information they need from their doctor. They have a lot of questions about bracing, et cetera. So we're addressing all these things. So, but let's get to some of the specific ones here. And there's a lot here. We'll try to get to everybody's. Final thing, actually, pretty exciting. One of the offerings we have is what we're calling an office hours, and they will be with different types of specialists. Again, orthotists, past patients, national experts. This Friday, we're excited that our inaugural office hours will be with the man himself, Dr. Voorhees. So you'll have a chance to ask him some questions directly this Friday sometime. I think we're finalizing, but 9 a.m. Pacific. And so sign up for the membership and you'll get to talk to Dr. Voorhees briefly during that session. So John, getting some quickly. So these are some maybe, difficult questions. In your take, is scoliosis hereditary, just generally?
Yeah, so there's a couple questions that ask about that. So it's not hereditary in an easily definable sense. So there's some things where if you have a certain disease, we know that your child has a 1 in 3 chance of getting it. And it's not like that. So many really smart researchers have spent their entire careers trying to find a gene that you can test for, or a bunch of genes that you can test for to try to quantify the risk that somebody has scoliosis. And it's really challenging to do. We do think that it is related to genetics or epigenetics. So there's some sort of code that you are born with that programs your child's spine to grow with scoliosis during periods of rapid growth. And that's why it's most commonly found in these periods of rapid growth during adolescence and sometimes more rarely in infants. And we also know that if you have a family history of it, if your mother or your father has it, you definitely have an increased risk of having it, but that doesn't guarantee that you'll have it. I just saw a kid yesterday, actually, whose mother had very severe scoliosis. She was treated with a brace and ultimately underwent surgery. And so she's been very vigilant, understandably, about her child. But the child has a perfectly straight and normal spine. So that's a pretty common occurrence. So more often than not, if you have scoliosis, your child will not have scoliosis, but they do have increased risk relative to the general population. And that might be a reason for you and your pediatrician to be more vigilant during adolescence to watch for it developing.
Great, thanks. So quick comment. Brent asked or had a question about rapid onset scoliosis. Brace helped prevent progression, still has pain. Is physical therapy an option? And so I would say physical therapy is a great option. And this is one of the focuses of what we're doing there. There are some virtual options in the National Scoliosis Clinic to help back pain in patients whose curve is present, but maybe in the moderate to severe range. So I'd encourage you to check that out. And then related, Diana asked a question, and you touched on this, John. What's your opinion about Schroth method as a specific method of physical therapy for scoliosis in general?
Yeah, so I have to be totally honest with you. My opinion has changed as a result of research over the past several years. So I think the traditional teaching by MDs is that we've been in opposition to therapists for a long history of this, and that many scoliosis doctors 20, 30 years ago didn't really believe that physical therapy could have an effect on scoliosis. But as research keeps coming out over the past several years, we have found that there is a measurable effect that therapy can have on scoliosis. It does not seem to be as profound an effect as bracing, but it is real. You can measure it on an X-ray, and you can measure it in patients' quality of life, so how patients feel and how patients look. And so most of the research that has come out has been on Schroth, and that's probably because it's just the most prevalent. But I am optimistic, and I think that it is likely that if Schroth has an effect, that there might be some other measurable effect from many of these other therapeutic modalities. And I think that scoliosis is idiopathic. We agree, and idiopathic means that we have no clear identified mechanism or cause. And so in that situation, I think it's appropriate for MDs to be humble about what we know and what we don't know about scoliosis. And so there's a lot of people out there with a lot of different ideas that make a lot of sense for how to treat scoliosis, and we're open to that. And so I'm really excited to see new research coming out every time we go to these meetings. We're participating in some of that research here at Stanford, trying to better define who might benefit from physical therapy, what components of physical therapy might be the best, and how we can offer that to our patients. But Schroth by far is the best studied one. I don't think it's the only effective one, but it's certainly the one that we have the best evidence for right now.
Thanks. And so there are some Schroth therapists who are very adept in providing this in a virtual setting. And so we're working on incorporating that into our offering as well. Next, just get to Lindsay. Lindsay, thanks for detailing your family situation. I think this is actually just a classic situation of diagnosed with scoliosis, daughter diagnosed, very mild, but she's also very young, saw a specialist who said, come back in 6 months, but there's a family history of scoliosis. And as very often happens, the family's not comfortable with just waiting and seeing, because if that child hits a growth spurt during 6 months, things can change rapidly. And so try to get a second opinion, unable to get in to see that second opinion person for months. And so this is one of the things National Scoliosis Clinic is designed for. So we've got virtual scoliosis experts to give second opinions. And when the scanning device becomes available, which is hopefully soon, we'll have the ability to track the scoliosis from home monthly instead of waiting 6 months to make sure we're not missing a rapid advancement. And another participant mentioned their child had rapid advancement of 36 degrees or something in a very in a window that happened not to be monitored. And so these can get missed if the interval between monitoring sessions is too long.
Yeah, so this example is something that really motivated me to be excited about being part of this project, because I mean, we have people in the Q&A. One person says, you know, they have a child with a curve that really advanced rapidly and caught them by surprise, and somebody else who says, you know, I have a small curve and I don't want to sit on it and wait. And you know, I think the way our system is designed, when I see somebody who has a mild scoliosis, I just have a really brief window of time that's allotted for me to counsel the family, give you all this information that we talked about today on scoliosis, and then make a plan. And I think, you know, for somebody with a very small scoliosis, I do the same thing. I'll follow them in 6 months. I think that's a reasonable time to get another X-ray, and I wouldn't want to expose your child to too many X-rays over the period of time. But it would be so wonderful, you know, if you had another option for where to get information, for a second set of eyes, some sort of ability to keep track of things and to do rather than just wait, because that waiting period is really unpleasant and understandably nerve-wracking for families, because you don't want your child to fall into this category of somebody whose growth catches us by surprise and we miss a treatment opportunity.
Yeah, thanks. Another participant, Liz, thanks so much for the details of your situation. I think also pretty common. 10 years old, 10-degree mild scoliosis. Doctor recommends an overnight brace. Seems premature to you. You know, you'd like to get some more information either from another specialist or from a bracing expert, an orthotist. And so those are all things that we can help you with. John, how about in general? I'm sure you know this comes up a lot. How does posture affect scoliosis? Can you make scoliosis worse with bad posture?
This is a super common question. I think I get it 80 or 90% of the time when I see a patient with scoliosis. So I think of posture and scoliosis as different things, but they're related. So somebody without scoliosis can have bad posture. They can slouch, they can hold their shoulders or their chest in a certain way. And somebody with scoliosis can as well. And sometimes they have the same postural issues, but then scoliosis itself tends to affect your posture in very specific ways. So a lot of the things that we're measuring with this research project about 3D scanning is postural. So for example, the way you hold your shoulders when you have scoliosis. I don't have scoliosis. I can move my shoulders up and down, and all that is posture, right? So posture is a decision that you make, and that decision might be influenced by the position of your spine at baseline, but you can also make a decision to hold your back in a different way. And so a lot of what physical therapy does is training a child to be aware, child or adult, anybody with scoliosis, to be aware of those conscious or subconscious decisions that you're making about how to hold your back. And I think it's too early for us to know in sort of the research realm whether or not, you know, correcting posture in a growing child might change your risk of having real growth mediated scoliosis progression like the brace does. But I think that we definitely know that if you change your posture, if you become aware of your body and you correct those things like trunk shift and shoulder balance, that it makes your curve better. And it makes these 3D parameters that we can look at when we look at somebody's back better. And so I think that's a lot about the effect of physical therapy and why physical therapy is becoming such a much more recognized important modality for how to treat people with scoliosis. Yeah,
thanks. And do patients need a prescription to get physical therapy with Schroth?
So it depends. So, you know, the landscape of Schroth is changing in the country. It depends on where you live. It depends on your insurance provider. So many insurance companies will pay for Schroth therapy. And so there's a mix. You know, I'm in the San Francisco Bay Area, and we have some providers of Schroth here who work entirely outside of the insurance system, because for a long time it was hard for patients to get their regular health insurance to pay for Schroth. So some of it is out of pocket. But a growing percentage of people are getting their Schroth care paid for by their regular health insurance. And to do that, you need a prescription from a physician. But you don't need a prescription to take advantage of some of the therapeutic options that people offer online, and to do exercises that might benefit your posture and benefit your core strength.
Yeah, perfect. Thanks. Somebody asked, how can we get the 3D monitoring app? So actually, we can make it available to you, again, with the caveat, it's not approved yet for diagnostic use, but it can be helpful, and there are still ways to use it without quantifying the Cobb angle precisely. So if you message us through the website, we can get it to you to use. John, what sports are okay for a child with scoliosis?
Yeah, this is also another super common question, and one that I have to be honest for. We don't have great data to understand if there is a big effect of what types of sports. I generally tell people that the overall benefits to health of your kid participating in a sport are so great that I wouldn't say don't do a certain sport because I'm worried about scoliosis. So a lot of people ask me about asymmetrical sports, like racket sports or baseball or something where you're throwing or swinging a racket with one arm and saying, well, is that asymmetry going to affect my child's risk of scoliosis development? We have no specific evidence to suggest that participating in asymmetric sport might worsen scoliosis. So if your child loves that and that's what gets them, excited and builds their strength and gets them active and healthy, then you should continue to do that. I think you should rest assured that things, another common question is about backpacks. People like to carry heavy backpacks on one shoulder. That can definitely cause back pain. But if it doesn't cause back pain, as far as we know, it doesn't affect the risk of scoliosis progression. And the sort of reassuring anecdote that I give people about that is, the brace that we prescribe for scoliosis. So it's designed to push on your ribs and your hips and change the shape of your spine. If you wear that for under, 4 to 6 hours a day, it doesn't really have a significant effect on the direction that your scoliosis goes. And we know that from the study that I showed you earlier today. You have to wear it over 12 hours, really upwards of sometimes 18 hours to have an effect on brace. So unless your kid's carrying a one strap backpack for 18 hours, I don't think you have too much to worry about.
Great. That's super helpful. Thanks. So maybe just one last one. Is there a kind of known threshold for a curvature number that will lead to neck or back pain later in life?
That's a great question. And we don't have a threshold or a great understanding of that. And that's because back pain is just one of the great mysteries of medicine, honestly. It's super common. A lot of people have it in the absence of scoliosis. And there are many people with scoliosis who look like they ought to have back pain based on, predictive algorithms, but they don't. So the reasons for back pain are very complicated, and the experience of pain is very unique and depends on each individual's situation and their genetics. So we can't really tell you. We can give you overall sort of risk categories, and so we know based on some many great natural history studies that somebody with untreated scoliosis that's in the 40s or 50s, as they get older, they will tend to report higher rates of back pain than people with no scoliosis at all. And people with no scoliosis at all still have back pain. But as your scoliosis gets larger, and somewhere around the 40 to 50 mark for most curves is where we see sort of a split off, and people tend to have higher rates of back pain than the general population. But it's a little more nuanced than that. So where the curve is and how it affects your posture might also affect your risk of back pain. So a lot of people feel like smaller lumbar curves might be more likely to cause back pain than larger thoracic curves, and there's some data to support that. But the truth is that it's very individual. So when we talk about treating scoliosis in older patients, people who are done growing, I'm much less focused on these imperfect X-ray measurements like Cobb angle, and more focused on how a patient feels. And that's how we really guide treatment.
Awesome. So I think we'll probably wrap it up here. Thank you so much, John. Dr. Voorhees, really, really insightful and helpful. We will send you all a recording of this webinar. Go to nationalscoliosis.com. We've got a discount on a membership. Speak to John on Friday, and a number of other resources to help you and your family with all your scoliosis needs, and you can have an appointment with some of our clinicians as well. So thanks you all, and look forward to seeing you soon. Thanks again, John.
Thank you.